We're going to talk a little bit about the NHS, partly because if you're applying for medicine, at least this is what you're likely to be signing up for a big chunk of your life. That's unfortunately less true for dentistry, and we'll talk a little bit more about that later. But in the short term, we're going to talk about it because it's something that you're going to need to know about for the purposes of your interview. So if you look at the sort of waffle that the universities put out in the prospectuses to describe what kind of attributes you're going to need as an applicant, they almost always talk about the NHS, and specifically these are the sort of things they say that they need. So they want commitment to the NHS. If therefore you're sort of a Trump supporter, somebody who believes that anything to do with big government is a bad idea and that everything should be privatized, you need to keep that to yourself for the purposes of your interview. You need to have a little bit of understanding about what the NHS is and how it works. Not any great detail, they're not going to expect you to know what the administrative structure is or anything like that. It's really just the principles that it's founded on. But you also need to recognize that there are difficulties with the NHS and not have too rosy a picture. So you need to be able to talk a little bit about the challenges it faces and discuss the sort of ways that we might attempt to make things better. So if we begin by just asking the question, why is the NHS a good thing? The obvious starting point is the reason that it was founded in the first place, which is that it provides healthcare that's free at the point of delivery. That means that you go into the hospital, you don't have to pay anything. Obviously, that's not completely true. There are things like prescription charges and stuff, but generally, the overwhelming majority of the costs are met not by patients paying when they need attention, but through tax that people pay. And the point about that is that taxation, the level that you are asked to pay, depends on how much you earn. And therefore, people who can afford more end up contributing more towards the cost of the health service. And that means that people can go to the doctor without worrying about, is this going to cost so much money that it's going to be, difficult for me to pay the bills? And that was why it was set up in the first place, because it didn't used to be like that. The man in the picture is Aneurin Bevan, who was the health secretary in the post-war Labour government, and he set up the health service. And that was the principle, and you can see that from his quote that it was set up for. But if they ask you why is the NHS a good thing, that's the obvious and the most important answer. On the other hand, everyone is going to say that. So if you want to stand out from the crowd, you need to be able to think about other things that are good about the NHS as well. So, for example, in addition to those first two, you can talk about the fact that healthcare is a high-tech, expensive business these days, and it's difficult for a doctor working in isolation to have access to all that kind of technology, whereas by having a nationwide system, it can be made available to everyone. There's the issue of national coordination too, in the sense that the way people treat different conditions can be coordinated so that when someone learns how to do something better, they can share that knowledge and everyone can benefit from the advances that are made. And that's really important because otherwise it becomes very haphazard and you may have much better access to care for particular conditions in some parts of the country than others. But by having a coordinated health service, that shouldn't happen. Coming back to the cost issue, drugs, for example, are immensely expensive. And one way to try to cut costs is to talk to the drug companies and say, well, can we strike a better deal on this? And if you're just an isolated doctor in a surgery and you phone up some multinational giant like Glaxo or something and say, I want to pay less for my drugs, well, that Glaxo's just going to laugh at you. But if you're the NHS, you can do that because you're such a huge customer, that they're going to listen and they're going to strike a deal. And that the NHS has been very successful at that. And it saves an enormous amount of money, which is therefore available to spend on other aspects of the healthcare. And the final one on that list is a bit more vague, I suppose, but it's this idea that because NHS has very clearly defined values, so for example, that the way you'll be treated, your right to have care is not dependent on how much you earn or what color your skin is or anything else like that, that everybody knows that that's the case. And so you can go along to a GP or to a hospital and have confidence that you'll be treated right. And again, that makes a huge difference to having an effective healthcare provision in society. So those are sort of things you can talk about when you're considering why is the NHS a good thing to have. We should mention that it isn't the only player on the field. There is private healthcare in this country, but it's not a big player really. So in terms of acute care, in other words, if you suddenly become ill and you want someone to tell you what's wrong and provide some treatment, 97% of people will go to their NHS GP or to their NHS accident and emergency unit. So it's overwhelmingly the dominant player for that. When it comes to elective care, that means non-urgent operations that can be sort of planned in advance, that kind of thing. Then there's a somewhat bigger role, but it's still less than 10% played by the private sector. It's a bit bigger than in acute care because of waiting lists. So one of the big problems the NHS has, and this is what we're going to talk a lot about, are the long waiting times that come from the heavy demand that it faces. And obviously, if you, for example, need a hip replacement or something, you really don't want to hear that you're going to have to wait months and months and months for it. So if you can afford it, you can reduce that time potentially by going private. But as I say, it still only accounts for a small minority of what is provided nationally. The NHS is the dominant player. Dentistry, unfortunately, is a rather different story. So it was set up as a national thing in 1948 at the same time as medicine was. And for a long time, it was, again, absolutely the dominant player. So over 95% of the dentistry that was done was carried out under the NHS. The problem was that it was sort of a victim of its own success in that when it was first introduced, it was just overwhelmed with people wanting dentistry because a lot of people had really never had that before. Dental health prior to 1948 was terrible in the UK. And the problem was just that it was becoming difficult to find the money to fund that. So the idea of dental charges was introduced, and that was sort of the start of a slippery slope. And it became increasingly complicated for the dentists and the government to sort of negotiate, how they should be compensated for the work they were doing, and how that should be balanced with what people were paying as individuals. And essentially, over time, they fell out over this, and the dentists felt, with some justification, that the way the NHS was paying them was just unfair and didn't reflect properly what they were actually doing, nor did it sort of encourage them to do what they felt was best. because they were constrained by what they could be paid to do and what they wouldn't be paid for. And the result was that in the end, a lot of dentists started leaving the NHS and just operating privately. And that's now become the dominant thing. So more than 60% of treatment is private in this country, and that's always increasing. So that now means that in some parts of the country, it's essentially impossible to get NHS treatment. And, that's a huge problem because it is, again, creating a societal divide where people with the least money are struggling to get dental treatment. What's happening now is that the majority of dentists will not take on new NHS patients, including children, so they won't take on children for NHS work. And that's going to mean over time that there's a serious risk of NHS dentistry dying. So we're not going to talk more about that today. If you're a dentist, I will put together a presentation that gives you a bit more detail on that story, because it is something that you definitely need to know about. So let's ask the question, do people still support those founding principles of the NHS? So this was from, I think, a 2023 survey. And you can see that when they asked the question, should the NHS still do what it does, provide care free of charge when you need to use it? And overwhelmingly, people said, yeah, they definitely agreed with that. 77% said definitely, and over 90% said at least probably. But when you pick that apart a little bit more, you can see that people were a bit less enthusiastic about the sort of universality of that, the idea that the NHS should be available to everyone. But the really disturbing and important result from our point of view was when they asked, should it continue to be funded primarily through taxes? And then people were much less sure. And that's the problem, that people like the idea of having healthcare that's they don't have to pay for when they need it, but they don't really like paying taxes. So if you ask them, well, if it's not going to be funded through taxes, where's the money going to come from? And people say, well, that's not my problem. The government has to find the money, but the way government finds the money is through taxation. So there is a disconnect there, and it is a really important one, because if we're going to improve the NHS, it's going to be difficult to do that without finding more money, and it's not going to be easy to find the money. That's really, really important. We'll talk more about that in a bit. It's worth comparing it briefly with what happens in other countries, because you quite often see in the media, comparisons about how much better it supposedly is in continental Europe or in Canada or somewhere. And people sort of say, oh, maybe that's because the NHS is a sort of outdated system. But actually, when you look at things, some countries do actually have a system very similar to ours, so Italy, Spain, and so on. A lot of others use what's called a social insurance system, and the idea there is that instead of receiving money through tax, people pay into an insurance company, and then the insurance company then pays for the medical care when it's needed. But the important thing is that in countries that have a social insurance system, it's compulsory, so everyone has to do this. So it's not like you have a choice. So it's not that different from tax. And again, not that different from tax. How much you pay is related to your income. So really, although it's a different way of organizing it, the principles are essentially very similar to those of the NHS in those kind of systems, in that what you pay is related to your ability to pay it, and everyone has to contribute. In the end, largely things are free at the point of care. So you shouldn't get the idea that we're sort of a complete outlier from everywhere else. It's not really all that different. The country that is a complete outlier is the United States, which just doesn't have anything comparable to the NHS. So most healthcare is completely private in the United States, and depends heavily on a private insurance system. And the problem is that people with the lowest incomes struggle to afford any kind of meaningful insurance. So they do have a sort of safety net system, Medicaid and Medicare. But the Trump administration is trying to cut back on those things too. So healthcare in the United States is a mess. And I think it's important to know that privatization, going down a route where you don't have some kind of organized social system for controlling how the funding is organized, is probably not a direction we want to go in. So we can sort of judge how successful the system is by looking at things like, well, how much money do people actually end up spending on healthcare over and above what they've paid for through taxation or through social insurance or whatever, and just comparing that in different countries. And so you can see that the United Kingdom is right over there on the right-hand side in this diagram, meaning that the amount of money that people have to spend sort of out of their pocket after they've paid their tax bills is really very small in this country compared to lots of other places. So people in Switzerland are paying 3.5 times as much out of their spending money for healthcare as people in the United Kingdom. So it is doing a good job of making sure that as close as possible, healthcare is free at the point of delivery. A really interesting way of looking at that issue is to say, well, okay, if you sort of have to pay a little bit for prescription charges, that kind of stuff, it can be annoying, but it's not usually devastating. But you can imagine if you have a complex, serious illness and it goes on for a long time, then if you're having to meet a significant fraction of the actual costs of your care under those conditions, it can become absolutely crippling to the point where you may have to sell your house to fund your treatment or something like that. And one thing that the NHS does really, really well is make sure that that doesn't happen to people. So this graph just attempts to quantify the risk of being faced with catastrophic healthcare costs, which sort of have a serious impact on your sort of family's life. And again, you can see that we do really well at that. So the United Kingdom is right over there on the left-hand side, meaning that there's a very low risk of that happening. Whereas in a lot of other countries, it's much higher, 10 times higher in some cases. So again, because we're mainly going to talk about the problems that the NHS has, it's important not to lose sight of the fact that for all that it does have problems, it's doing a good job. It is a very effective system for making sure that everyone gets looked after and no one is financially crippled by doing that. Even so, if you ask people, well, are they satisfied with the way the NHS works? Over time, the picture's been very mixed. So if you look at the purple line there, those are the people who are very or quite satisfied with the NHS. And you can see it's varied quite a lot over time. So during the 1980s and 90s, it sort of rattled around 40 to 45%. So, the majority of people in the country were not satisfied with the NHS at that point. And then from about 2000 onwards, it started increasing sharply up till 2008. And then it stopped increasing and there was a gradual decline. And then in the last few years, there's been a really steep decline. So it's worth picking that apart a little bit and saying, well, what caused those changes? So the change in around 2000 came about because that was shortly after the Tony Blair government took power, and they decided to make a commitment to massively increase spending on the NHS, both in terms of running costs, but also actually by building a lot of new hospitals and facilities and things. And that was what led to that increase in satisfaction during those years, that peaked at 70% satisfaction. The way they did that was slightly controversial, and we'll perhaps mention that a little bit later. Because again, the problem is, where do you find the money from to do that? But you can see that spending money does produce results, because the satisfaction with the service provided increased a lot during that period. And then in 2008, we had the financial crisis. And then suddenly there was much less availability of money. And that was why the satisfaction started to drop, because the level of provision started to get less good. But what's happened very recently is that it's absolutely plummeted. So from around 60% still, just immediately before COVID, to something around in the sort of 25% region today, and that's a huge and sudden drop, and that's obviously something that we need to be really concerned about. So why are lots of people dissatisfied with the NHS? Well, when you ask them that question, overwhelmingly the dominant answer is the waiting times. Okay, it takes too long to get to GP appointment or to get anything done in hospital. If you go to A&E, it takes ages to get to the point where someone actually gives you some treatment. All of those things are the sort of things that people get upset about. And if you look at the other things on that list, they tend to be just different ways of looking at the same thing, really, because not enough NHS staff is the biggest one. But really, that's just people's interpretation of why it takes too long for them to get attention, that they're assuming that that's because there aren't enough people to provide it. And again, the government doesn't spend enough money is a sort of saying, well, that's the reason why there are waiting lists and all that kind of stuff. So really, it's dominated by that one big, very difficult issue. So we should ask the question, well, should we actually just spend more to make the NHS better? And again, it's interesting just to do a quick comparison with other countries and see, well, are we particularly mean in how much we spend? Is that a problem? And you can see, actually, no, that's not the case. So again, this comparison with lots of other developed countries, you can see that we're towards the higher end in terms of how much of our national wealth we spend on healthcare. It's by no means at the top. The outlier at the top, you can see, way out of line with everyone else, is the United States, because of their not having a sort of national system in the way that we do. But compared to most other countries, we're sort of there or thereabouts. So although the way we organise it is slightly different, the amount we spend is not particularly out of line with our neighbours in Europe and so on. So if we want to increase the amount we spend on the NHS, because of the way we organise it, that tends to mean that we need to tax more. because otherwise, the government obviously only has a sort of more or less fixed input of money. And so if we're going to put more into the NHS, we're going to have to put less into something else, and that's not going to be popular either. The hope always is that the economy booms, so there's just more money out there, and then more money will naturally flow in through taxation. But at the moment, anyway, that's not really where the world is. So it doesn't seem very likely that that's going to happen anytime soon. We saw in the earlier picture that there was a sort of big growth in the NHS during the early 2000s. A lot of the funding for that, so the building of new hospitals that happened in the Tony Blair and Gordon Brown regime, that was funded by something called the PFI initiative, private finance initiative, which meant that although public hospitals were being built, the money for doing that came from private companies who ended up essentially owning the fabric of the hospital, and the NHS then more or less rented it from them and has to pay them back over a period of years, and we're still paying for those things now. And some people argue that that's one of the reasons that the NHS is struggling today, because a significant proportion of its income has to be spent on paying back for those PFI initiatives back then. And that's a political discussion that we won't get into here, but you can see that they did that because it was the only way they could find to get the money to build the extra hospitals that were needed, but it wasn't a perfect solution. And that's going to be the difficulty. So the point I'm trying to make is that if you're in a university interview and they ask you, what do we need to do to improve the NHS? If you just say, well, you should just spend more money, they're going to think, well, that's a very simplistic answer, because partly they're going to want to know what exactly you'd spend the money on, and we'll talk much more about that as we move on. But also, I think it's important to be aware and show that you're aware that you've got to find that money somewhere, and that because of the way people think about money in this society, that's not an easy thing to do. So if you do the obvious thing and say, well, should we increase taxes? Again, if we look at a survey, so on these pictures, this is broken down by income group. The orange bar represents the fraction of people who think, no, we shouldn't increase taxation. And you can see that over all the income groups, that's the majority. No one feels that they're awash with money and wants to contribute more of it. And even when the place that the money would go is something that people overwhelmingly support, like the NHS, they still don't really want to part with more money. And that's in some ways reasonable. It's a natural response, but it doesn't square with the fact that people want the NHS to improve, and it is a huge issue. And you can see that the fraction of people who are okay with paying more tax is lowest actually for the people who earn the most. So the people earning over 60,000 a year are the least willing to pay more tax. And you might think, oh, well, that doesn't seem right, because surely they've got more money available. But of course, the point is, it's not as simple as that they will be paying higher rates of tax, and so they would be disproportionately affected by the amount of extra tax that would be likely to be taken from them. So, this isn't a blame game. This is just a case of saying, well, everybody is kind of reluctant to pay more. And the thing is, we live in a democracy. So if a political party says, well, okay, but we think you should, so that's going to be our policy, we'll put a couple of pence in the pound on the income tax rate to enable us to improve the NHS, people aren't going to vote for them and they're not going to get into power. And so these days, very seldom do you see parties actually saying we're going to increase taxation, because they know they won't get elected, and that's the problem. So let's have a look at this issue of waiting times. So we haven't got time to look at all of the aspects of that, so I've just picked one of them, which is the waiting times in A&E, and I thought we'd just try and pick that apart a little bit. And you can see the scale of the problem from this picture. So this is just looking back over the last sort of 10 to 15 years at how likely it is that you're going to have a long wait in A&E before you get treated. And back in 2012, you can see only around 5% of people would be expected to wait more than 4 hours before they got treated. And today, that number is over 40%. It's a massive, massive increase in the risk of you having a long waiting time in A&E. So there is a huge problem there that we have to try and understand. And once we understand it, see if we can find a way that we might try and improve things. So if we ask what causes the problem, we can come up with all kinds of things that might be happening. And one of the problems you find when you read about this in the media is that a lot of people jump to conclusions about what's causing the problem without really picking the data apart. Now, in your preparation for applying for medicine, it's not that you're expected to develop a detailed understanding of all of these things. So we'll go through some of this morning, and it's not that you've got to memorize this, it really isn't that, but it's just to give you a feeling for what some of the issues are, that and make you aware that this isn't a simple thing where you can point to one thing and say, right, that's the problem, therefore that's what we need to deal with. That it isn't as simple as that, and that some of the things that you might think are the things that we should target might not actually help if you targeted them, because they're not actually the major limiting factor at the moment. So let's think of examples of things that might be causing waiting times to have increased. So one thing that people often say is, oh, well, it must be because more people are turning up at A&E, so there's just more demand on the system. If you look at the data on that, you can see, so looking at the top line, which are the sort of major hospital A&E departments, that the number of people turning up is rising. You know, it's not sort of a dramatic rise, but it's gone up from sort of 38,000 or so people turning up every day in 2011 to, you know, sort of 45,000 today. So that's, you know, it's not a trivial difference, and that is going to be a factor. The big blip around 2021, of course, is what happened during COVID, when far fewer people were coming into A&E. So disregarding that, you can see it seems like a sort of steady rise, although interestingly, it seems to have kind of leveled out a little bit in the last few years. So that could be part of the problem. Obviously, the more people that come in, the longer they're likely to have to wait. But it doesn't seem to account for the very steep rise in the last few years. Before we move on from that, though, let's just ask the question, well, why are there more people turning up for A&E? And the obvious answer might be, well, maybe it's because the population is getting bigger, and indeed the population is getting bigger. So this is looking over a much longer time scale, where you can see that back in the 70s, we had a population of around 56 million, which was quite sort of stable back then. And, you know, it's now in the high 60s of millions. So it has increased a lot over that time. And that's inevitably going to mean that, you know, if roughly the same kind of proportion of people need medical attention on a given day, that the numbers turning up to A&E are going to increase. And that is part of the picture, but it isn't as simple as that, because if you think about the distribution of people within that population, this picture shows a really important trend. So this is analysing the population by age group. So in these slightly weird graphs, age is the parameter on the vertical axis. So newborns are at the bottom and centenarians are at the top. Okay, so you can see that the overall sort of size of the body of the graph is getting bigger from 1966 to 2016 and is projected to get much bigger still. That just represents the overall population getting much bigger. But looking at the width of the bands tells you about the relative numbers in different age groups. And you can see in 1966 that the numbers over 70 were really very small compared to below that. Whereas if you look in 2016, that's much less dramatic. Okay, so the whole graph is becoming more top heavy than it was back in 1966, because people are living longer. Fewer people die in early life and middle age than they used to, and therefore the shape of the graph changes in that interesting way. And in part, that's a triumph of the NHS. And it's obviously not just the NHS, but it has played a major role in doing a better job of keeping people alive for longer. So it's a good thing, but it means that a bigger proportion of the population are old, and of course old people are more likely to need medical care. So one of the factors that's also going to be driving that increase in the number of people attending A&E is likely to be that there are more old people, and they're more likely to have falls or have sudden illnesses of some kind that need urgent care. And that's going to be a factor. And the predictions here for 2066 suggest that that's going to become a much, much bigger factor. So we need, in planning for the future, to take account of the fact that there is likely to be considerably bigger demand because of the change in the population. Okay, so what we've seen is that increased attendance is a factor, but it doesn't account for the steep rise in the last few years. So again, something that people often point to is, oh, well, is it just because there aren't enough doctors and nurses and people providing the healthcare? So am I waiting for hours in A&E because all the doctors and nurses are busy looking after other people and they haven't got time for me? So again, there is some evidence that we are quite mean in terms of the numbers of doctors, certainly that we have per head of population. So again, this compares us with other countries in Europe, and you can see we have fewer doctors per head of population than the great majority of other countries. And compared to Austria at the top there, we have far fewer. So maybe that supports the idea that the reason that we have problems is because we don't have enough doctors, and it's worth knowing that successive governments have sort of acknowledged that, and there is a plan to increase the numbers of people entering medical school very markedly over the next few years to try to deal with that problem. But again, obviously, taking more people into medical school is one thing, but once they're qualified, you've got to find places for them in the hospital, and that means you've got to find money to pay them, and that's a problem which I'm not sure has been entirely thought through. So it is likely to be the case that there will be more doctors in the future, but it's going to create a bigger financial stress. And we've not really got a very good way of dealing with that. So it remains to be seen how easy that's going to be to achieve. One thing that I think is really important, though, is that I think a lot of people imagine that the shortage of doctors and nurses means that actually there are fewer of them than there used to be. And that's really not the case, which is what this figure shows. So if you look at all these different lines, they represent different groups of people operating within the NHS. And you can see that the numbers of almost all of them have increased really quite significantly over the last 15 years. So doctors are the black line at the top. And you can see that compared to 2009, there are almost 40% more doctors now operating in the NHS than there were then. So that's a big number, much bigger than, for example, the percentage change in the population that they're serving. So we can't say, oh, we just haven't met the need to continue having the number of doctors we need in a simple way like that, because there has been an attempt to increase that number quite markedly. If you look at nurses, you can see it's a slightly less rosy picture. The number has again increased, though only by about 15%. So that may mean that we shouldn't focus always just on doctors, but think about all the other people that you need as part of the medical team, and make sure that those numbers are keeping up as well. And really the only group whose numbers were allowed to dwindle for a long time were the infrastructure support people. So people, keeping the hospitals clean and making sure that the equipment continued to work. And it was easier politically to sort of neglect those groups a little bit, because the media gets very upset if they say, oh, there aren't enough doctors, there aren't enough nurses. If they say, oh, there aren't enough cleaners, then people don't get so immediately upset. But obviously, actually, if you don't keep the hospitals clean, if you don't keep the equipment working, then there's no point in having lots of doctors and nurses, because they haven't got an environment they can work in. And so in the last few years, I think people have woken up to the fact that actually that was a bad idea, and that we do need to increase the numbers of those people too. So important thing there is to say, well, there are staff shortages, certainly in some sectors, in some places, but it's not the case that we've just failed to recruit any more people, because the numbers have increased a lot. There are large numbers of unfilled posts, but it isn't totally clear that if we were suddenly able to fill all those posts, that it would magically make everything all right. And this picture is quite startling. So this just looks over the last few years, so over a window really from 2019 to 2023. So obviously COVID came in the middle of that, but just comparing with what it was like then and what it's like sort of more or less now, there has been a huge increase in the staffing levels. So those are what the green bars represent. And looking at junior doctors, for example, they've increased by almost a quarter compared to 2019. So there are a lot more junior doctors floating around than there were back then. And yet, when you look at the blue bars on the right-hand side, the number of people actually being treated hasn't risen appreciably. And in the case of emergency, treatment has actually decreased over that time. So what that says is that we can't just take the simplistic view that we should try and find a bit more money, recruit lots more doctors and nurses, and everything will be fine. because this evidence at least suggests that the numbers that we've increased the workforce by over these last few years, it hasn't successfully improved performance. So that means we have to think a bit more deeply. It doesn't mean that we should stop recruiting more people, because in the end we will need them, but they're only going to be effective if we can sort some other problems out. So another thing that people might think about is, why are we waiting around for a lot of time in A&E? Well, maybe it's not for the doctors, maybe it's for the diagnostic technology. One of the things that's changed in A&E a lot over time is how sort of technological it is. So in the old days, a lot of it would be just talking to the doctor about your symptoms, and they would do a few sort of simple tests and then decide what was likely to be wrong with you and proceed on that basis. But these days, a lot of it is done by saying, right, well, I think we need to test for this and we need to test for that. And so quite often, for example, they say, well, I think we need to have a scan to see what's really going on there. And that's brilliant, because you can get much better diagnosis, but it means that you tend to have to wait around to get the scans done and that kind of thing. So maybe that's an important factor. And again, you can see, if we do the international comparison again, that could be a big problem for us. Because if you look at the availability of scanners, so CT scanners or MRI ones, both of which are important in diagnostic processes, we do incredibly badly compared to most other developed countries in terms of availability of these things. So you can see that could be a major factor. If you compare us with Japan, they have more than 10 times as many of these things per head of population. So yeah, that could be a reason why people are spending a lot of time waiting around. But again, that hasn't changed dramatically in the last few years. So you have to ask, well, why would that suddenly have become an issue? So here's something then that has changed dramatically in the last few years. So this is now focusing on what happens after you've had your treatment in A&E. And essentially one of two things happens. One is that they say, right, well, we've basically sorted the problem out. You can go home now and you'll be fine. Or they sort of say, well, basically you're fine anyway, and they just reassure you. And that's not a problem. But for a lot of people, what the A&E department decides is that actually you're going to need to be admitted into the hospital. You need to go onto a ward, either for further tests to be carried out or for monitoring or something, or sometimes because something you actually urgently need some kind of treatment that can't just be delivered on the spot in A&E. So that comes to the next sort of waiting time, which is how long does it take to get moved on from waiting around in A&E to finding a bed in a ward. And that situation has got much, much worse in recent times. So the blue line is the number of people who wait in A&E for more than 4 hours. But it's important to be clear, we're not talking about waiting to be treated. It's after you've been treated. It's the number of people who then have to wait more than 4 hours before they get moved onto a ward for the next phase of their treatment. And you can see that's been rising steadily over the last 15 years. But in the last 3 or 4 years, it's been rising dramatically. The red line is perhaps the even more dramatic one, which is highlighting the fact that prior to sort of 2020 or so pre-COVID, it was almost unheard of for anyone to be waiting more than 12 hours in A&E before they got moved onto a ward. But now that's becoming a regular thing. So by now there are sort of getting on for 50,000 people a year who have that enormous wait, the trolley wait, as it's often described, as you're often sort of lying on a trolley waiting to be moved somewhere. And that, it's clearly unacceptable. and is something we need to do something about. But it's not just bad for the patients waiting on the trolleys, it's bad for the A&E department because, of course, it means that the space is taken up, and it limits the number of other people who can be treated. So effectively, the beds in A&E are blocked by people waiting to be moved on to the next phase. And that's why you see, for example, these pictures of ambulances queued up outside the hospital, because the A&E can't take the patients in because they're already full of people that they're trying to move on but haven't got anywhere to move them to. So that, the evidence suggests, is a major factor, because that increased enormously in recent times, correlating with the increase in A&E waiting times. So we need to think, well, why is that happening? So again, it's not a simple picture. The obvious answer would be, well, there just aren't enough hospital beds. And again, if we look at the evidence for that, that actually seems like a reasonable interpretation. So this is looking at the fraction of the beds in wards in hospitals which are actually occupied at any given time. And you can see that in around 2010, that number tended to be around 85%, and it's been rising steadily. Okay, so the number of beds occupied has been rising steadily. Again, there was obviously a big blip during COVID, but it's now sort of around the 90% mark, or rather higher than that, actually. And you might think, well, 85 to 90% isn't a dramatic rise, but if you think about that in terms of how many beds are free, if you like, it's decreased from 15% to maybe 8 to 10%, and that's a dramatic decrease in the number of free beds, and that's a problem, because you might think, well, okay, so long as there are some beds free, surely that's fine. But this is a national picture, remember, and in any given hospital at any given time, that might mean actually that there are no beds in an appropriate ward, and that's what the problem is. So that is an issue. And again, if you do the international comparison, you can see that we do pretty badly in terms of the number of hospital beds per head of population. So, compared to France and Germany, we've got only a small fraction of the numbers they have. Now, people historically said that this was a triumph for us because it meant that we were just being much more efficient at moving people through the hospital, so we didn't need lots of extra beds. But there comes a point at which that efficiency becomes a liability, and actually you realize that you've got rid of all these beds, but actually you need rather more of them. So there probably is a big issue there. But again, it hasn't changed dramatically recently. So it's something that needs attention. And as you said earlier, that's not trivial. It's not a case of just buying a few beds, because obviously you need the space to put them. You need the equipment that goes with them, and in particular, you need the staff that goes with them. So the cost of increasing those numbers is very high, and it's difficult to find the money. So that's what we need to do. But you shouldn't just sort of give the impression that you think it's an easy answer, because it's actually quite difficult to achieve that. This kind of highlights this problem for the UK compared to other countries. So this is talking about capital spending. In other words, not spending on the day-to-day costs of keeping things running, but actually buying more equipment, buying more beds, more hospitals, and seeing how well we do at that compared to other countries. And you can see over the last quarter of a century, we've consistently spent a smaller proportion of our national wealth in building hospitals and furnishing them with modern equipment than most other countries in the developed world. And that the only time that wasn't true was during the mid to early 2000s, during that time when the government had that real focus on trying to sort of modernize the NHS. But once it became impossible to sustain that level of spending, then it dropped, and it dropped precipitously. So we're now way behind most other countries. And that is a problem, because you can see that most of the things that we feel we might need to deal with are going to require increased capacity, either in terms of space or equipment. And because people don't want to pay more tax, it's very difficult to see where the money's going to come from to achieve that. So that's the problem that we need to address. But we still haven't really got to grips with what's driving this recent very steep rise in A&E waiting times. And this perhaps does provide some insight into that. So this is now looking at what happens in the next phase when people have made it onto the wards in the hospital and they get whatever treatment they need. And hopefully, most of the time, they then reach the stage where they're well enough to be discharged, where they don't need to be in hospital to receive medical attention. But the NHS can't release people unless they know that they can safely either look after themselves at home or have some kind of provision to be looked after once they're released into the community. They're just not allowed to kick people out, which is a good thing. But the problem is that a lot of people can't just look after themselves, that they need some kind of support out there in the community to make sure that they're safe and you know, as well as we could hope they would be once they're released. And what's happened in recent years is that an enormous number of people are getting trapped in the hospital wards because we're unable to make the provision to support them once they're released. And that's the thing which really is increasing dramatically at the moment. And that's what this graph shows. So this is the number of beds occupied on our wards by people who don't need to be there, who are basically waiting to be released. And you can see that you know, has changed a bit over the years, but it was sort of rattling around until the last few years, and now it's rising really steeply. The reasons for that, well, as we said, it basically comes to mainly finding ways to care for people once they're released. There are also delays caused by, you know, shortages of staff in the hospital. You know, that it takes longer for people to get the admin done for their discharge just because the doctors are busy and so on. And I mean, that is a factor, but it's not the big factor. It's that arranging provision of care that's the big factor. So this was an analysis just on a particular month a couple of years ago. And you can see that the overwhelming majority of people who were waiting around to be discharged were actually waiting to have their needs assessed. Okay, so it's not that they're waiting for medical assessment. They're waiting for someone to come along and figure out what kind of help in the home they need, or you know, whether they need to go into residential care or whatever. And that was a huge factor. If it had been decided they needed to go into residential care, there was the waiting to find a bed for them to go to, you know, a space for them to go to in a home, or into a community hospital rather than an acute care hospital. And then there are all sorts of sort of smaller reasons, but you can see those were overwhelmingly the big ones. So what that means is that actually, if we want to solve the problem of these spiraling waiting times in A&E, it may be that the place to spend whatever money we can raise is not directly in A&E, but actually is improving the social care at the end of this whole process. Because you can see what could happen would be that if we have better resources for social care, then it's going to be easier to release people from the wards. So more beds will become available on the wards, so it's easier to move people on out of A&E, and therefore there'll be less time spent waiting in A&E. It's a really complicated picture. And as I say, it's not that you need to be able to analyze that in depth, but it's showing that you have that appreciation that there aren't simple answers to these things. You need to be able to say more than just, we need to spend more money or we need to have more doctors or something like that, because it really isn't as simple as that. So that's really all we need to say about this. As I say, if you're a dentist, it is a very different picture, and I will produce a different analysis for you so that you can have some appreciation of that. But you need to have a positive view of the NHS for all of these problems. You need still to sound committed and a believer in the NHS when you go along for your interviews, but you need to have a realistic view of the problems that it faces. Okay, so we'll stop there.